weekend, right? Take some time for yourselves. It doesn't happen very often, and especially since you guys are getting that here in this semester. At least your junior and senior semesters aren't going to have a whole lot of 4-day weekends, so enjoy it while you can. Take some time for yourselves to, right, unwind, relax, whatever that is. All right, so a couple of things as I do things, I think about stuff that I should have told you yesterday, I forget. Testing, right, more testing stuff. Radiology is unique, we already talked about that. There are a couple of things you are going to be allowed to do for my exams that you cannot do for other exams, okay? You are allowed to zoom in for my exams when you get the pictures. Now, I will be honest, right? We don't have radiologist quality monitors, right? So yes, sometimes zooming in on a photo might make it a little more pixelated, a little more grainy as we call it, so it might be hard to see, but you are allowed to zoom in and out on my exams without having to raise your hand and have us watch you zoom in and out, right? You are allowed to do that. Also, some people already have it here, but you are allowed to, if you would like, to bring in external monitors that are larger if you want to make the picture look a little bit bigger for my exams to be able to do that, okay? You can bring it in just for my exam if you want, and then bring it home or whatever the case is. But those are a few things that aren't normally like hey, you could just zoom in on the exam all the time. There are certain rules I know you guys have. I just want to make sure that's clear that that is allowed in that aspect. Any questions on that? The only thing I'll say is if you are a monitor person and you want to like sit somewhere else where there's more room, just work that out with your classmates beforehand, so just don't move anybody out of their seats or anything. Any questions from yesterday? As I'm sure a lot of you dug into that after day one, right? You know how this works. Try to, but the first 3 lectures are very foundational. You need to know the concepts, but what is that little, is that on the projector? Okay. I just saw that. Temperature indicator, great. Let's hope it doesn't start fire right over you guys. That'll be interesting. Okay. Hey, it is an Army building, right? And we're lucky we have AC when we do. All right, let's dive into lecture 2. I know people are freaking out because there's like 800 slides to block 1. How many of you are freaking out about that? Be honest. Take a deep breath, let it go. A lot of the slides are just pictures, right? It's not 800 slides of words. It's not. Probably half the slides are pictures, especially once you get through these first couple of them. So I could make it shorter, but then you have less pictures to look at to understand what you're looking at. So you'll be okay. All right, so we discussed a lot of 2D imaging yesterday, right? We talked about radiology, x-rays, primary x-rays, how it's 2D, and you need those orthogonal views to be able to help you look at a 3D picture because your mind's going to play tricks on you. Well, what if you need something more than that, right? It's still not enough detail, and I need to figure that out, right? That's one of the things we're going to talk about today. For example, this guy, right? This is a bad day. Some of you, depending where you go through your phase 2, might be lucky enough to have the opportunity to see patients like this when you're on your ER rotation. And I say that because some of the sites' ERs are open to the civilian sector as well because they just happen to be the largest medical facility in the local area. So they will get some of this. Like I know BAMC here local gets stuff from off base. For my Air Force folks, at least when I was there in the past, Travis, sometimes their ER would get stuff from off base because they just were the closest medical hospital to where the NBA happened or the assault happened or something like that. So some of you will get to see stuff like this, but the problem we have here, right, is what do I know? I know he's been stabbed. I have no idea where, how deep, or any of that kind of stuff. Is it hitting any organs? And even if I just get a single x-ray here, that's going to be hard. And there's no such thing as a lateral abdominal x-ray, which we'll talk about later. But it's going to be hard to figure out exactly what is this knife penetrating, what are the injuries, what's going on. That's where we get into CT. And we're going to talk about CT a little bit today. We're going to talk about mammography today, and we're going to hit on MRI. Again, this is foundational stuff, giving you the concepts of what they are, how the machines work, what they evaluate before we actually get into reading the studies, okay? So, CT. So here, take a look at my notes and make sure I got the patient right. Yep, that's right. This is a CT scan of somebody who had COVID, right? What we're looking at, and I don't expect you to know this all right now, what we're looking at is a lung CT, okay? So these are different slices of a lung CT. The way a CT works, and we're going to talk about it, is it scans, right, the body, makes it in different slices, and then the machine can kind of flip it and give you frontal views, side views, and things along those lines. So you can get a better 3D picture of what's going on, right? And so now if I were to have the knife on this patient, right, I would be able to actually see how deep it was going, if it was affecting the lung, right, if it was going in or whatever on a CT scan, because I would be able to view that in this cross-sectional analysis. This is what's called a lung window. We'll dive into that a little bit later. But what it does is it helps us see the lung tissue really well. So if you look here in alpha, this right here, this part of the lung, the dark here and the little white lines, that's actually healthy tissue, okay? And then down here, we call the consolidation. That's unhealthy tissue. That's inflammation, that's fluid, right? This is a COVID pneumonia. So all of this is pneumonia, all of this is pneumonia. And this is all the same pneumonia here, just on different slices and in different areas of the lung. So you can see how much more detail this CT gives, just based off of the few chest x-rays we looked at yesterday, right? We looked at a couple, but the detail of it wasn't very good. It gave you a generalized idea of here's the lungs, here's the heart, you know, that kind of thing. But when you get into a CT, there's a lot more detail in that. So there are benefits to using this. Bad part, way more radiation than an x-ray. A lot more, and we'll talk about why here in a little bit. So we're gonna cover all the same stuff we covered about x-ray. Okay, so CT didn't come into the 70s. We talked about x-ray coming in like the late 1800s, right? CT not until the 1970s. And this is one of the first CT images, the cross-sectional images of the brain that was done. Very grainy, not super detailed, but it still is the only way that we've been able to look at that, because we talked about the attenuation and the absorption of the radiation, right? So bone is going to absorb most of it because it's the most dense. So when you see a skull x-ray, you just see the skull. You can't really see the brain because all the radiation is absorbed by the skull. So this is what kind of led them to that, is we need to figure out a way to look at the brain to try to figure out, are there any bleeds or what's going on inside of there, and that's where CT came about. It was done by Hounsfield and Comack. Again, it doesn't say it on the slide, but the history stuff is just background. I'm not going to pin you on years or who invented it. But they have a Nobel Prize for it, and now they have something in CT called Hounsfield units, named after the person who invented it, and we'll talk about that later. Here's what the machine looks like. How many have seen one of these? Right? Commonly confused with an MRI machine because they look similar. The difference is it's open, right? We call this the donut of truth, because you can't hide anything from a CT scanner. It will tell all. Donut of truth. So the way it works, and I think, there we go. Okay. So the way it works, and there'll be a YouTube video on this in the slides for you to look at, is it's very similar to an x-ray. It uses the same things, the same concept as x-rays. It's radiation still, it's photons, the electrons, the same process, right? The difference is, instead of just one machine shooting to one sensor or film or imaging plate or whatever you want to call it, within the circle here, there are multiple. Anywhere from 4 upwards of like 64 now that are in there. And so what happens is it spins, right? It starts spinning, and as the patient goes in, all of those things are shooting radiation and x-rays into the patient, and there's a receptor on the complete opposite side absorbing that information. Then the computer takes all that information and pieces together this 3D image for you based off of all those sensors. There's different kinds out there. The more slices you have, right, the better it is, the higher resolution. Most standard ones in a hospital now are like a 64 slice. When you're deployed, you should have at least a 16, and that'll be good enough. You don't have to worry about that. But the higher the number, the better the machine, the better the study you can get. But it's still regular radiation, so it follows all the same rules as what we talked about yesterday of bone is very light gray, metal is white, air is black, right? All the same rules. It's just more detail. Here are the different kinds of things you can get. So a knee x-ray, again, we just looked at, we could see one picture. We just see that one, right? Or the spine, or how I was like, hey, this is just one view, it's all superimposed. With a CT scan, you can actually scroll through and look at multiple images at once. So you can look at all the little slices, and we'll see here in a second what those slices are called and how they do that. So you can't see it here because it's a still image, but if I wanted to on an actual scanner, I could rolly ball or use my mouse and look at all the slices from the front of the knee, the anterior to the posterior, and just go back and forth all at once in one scan. So it gives you that level of detail. So you can actually see how in-depth this fracture is. How far does it go down into the tibia? Does it involve, you know, the femur at all, anything along those lines? You can actually do that. Whereas an x-ray, you might not be able to get that information. It can even do 3D reconstruction. So what this is they did the CT, and then they told the computer to do this. It reconstructed the knee on what it would look like if you actually had the bone sitting in front of you. So it can take that information and gives you a lot of info. Ortho uses this a lot. There's a YouTube video of how the CT scanner works for those that are interested to understand the physics behind it, right? And these are just more of the images that we're going to get. So you can see here now. Remember that chest x-ray? I was like, hey, you just have the heart, and you just kind of see the heart. Well, now I can see the heart, and later we'll break down the different chambers and everything. I can see the aorta. Here's the aorta. I can't see the aorta on a chest x-ray really very much. I see lung tissue here on the sides. I see each of the ribs with the vertebral column, each of the ribs with the vertebral column. I can make out my subcutaneous fat, muscles in the chest, muscles in the back, right? And then, this is how it gets scanned. This is called an axial slice, and we'll see this in a few slides. It takes it, and it will chop it left to right, or front to back, however you want. So you can scroll through and see now all of the vessels. This is what it looks like here. So right where I'm at on this guy and over here, this is what it looks like when I gave that contrast, right? This is the aorta. So thoracic would come down, and this slide just happened to start to show the thoracic down into the abdominal aorta. You can start to see some of the branches off into the renal arteries, but this is the aorta. If I didn't give contrast, it would just look like this here. It would look like this color, the gray color, because blood is fluid, is soft tissue, all looks the same under x-ray, right, or CT radiation. But if I give the contrast, now look at how much it's highlighting. It's highlighting where all the vessels and the fluid are, so I can see the difference between the two. So that kind of gives you an idea of why we'll give some of that contrast. Don't worry about reading these yet, right? You'll learn how to find that compression fracture right there. And we'll teach you guys. That's compression fracture right there. But we're not there yet. This is just basics, foundational stuff, right? So don't worry about it. You will, by the end of this, you will be able to find that. So I already explained to you kind of how it creates the 3D images, right? It does the sensors and stuff like that, kind of pieces it all together for you. What are the benefits in that? It expands the grayscale, right? So it better differentiates that stuff. Whereas you can see how on the x-ray, I was like, hey, yesterday, here's that subcutaneous tissue, here's some of that muscle. You can see a little bit of a difference in the grayscale stand out, but I also told you in the really fluffy patients, you may not, right? Well, when I go back to this, because of the detail, I don't care how fluffy they are, I can really see the difference between that subcutaneous tissue and that muscle, right? It expands that grayscale to make it easier to distinguish between those portions of the body in that aspect. Fast imaging. These are quick. CT scans are like less than a minute. A lot of times they're like 15 seconds once you get them on the scanner. So it's great for trauma, okay? So you get this a lot. Head injuries, neck injuries, sometimes abdominal issues in the ER. It's great for trauma. With one caveat. The patient must be stable. Must be stable. Do not, repeat, do not send an unstable patient to the radiology suite for a CT. Because you know what's going to happen there? They're going to code. They're going to code. Patients die in CT, not because the CT killed them, because for whatever reason in medicine, patients who are unstable always code on the damn CT scanner. I had to call code blue so many times when I was a rad tech. Like, it's insane. So, make sure the patient's stable before you send them to CT. You'll learn other methods of imaging to get what you need if they're not stable. We'll talk about that when we get there. 3D reconstruction, we talked about that. Just know that there's more kind of stuff coming. They're talking about, some places are doing virtual colonoscopies. So you, like with the CT scanners, I haven't seen it yet, but I know some places are doing it. So I don't have images of that per se. But calcium scoring, I've definitely done. CT coronary angiography. That's basically looking at the arteries of the heart, the cardiac arteries, and seeing if there's any blockages. The calcium scoring is super cool when you have these new scanners. You can have patients who are high risk for MI or high cholesterol or smokers or whatever. You can send them through the CT scanner, and it will show calcium that's building up in the coronary arteries prior to them even having an MI. So you can calculate a risk factor for them based off of that, possibly get them treatment before it even happens. So it's really advancing really well in medicine. It's very helpful. Here's just some more images. This here, pelvis reconstruction, right? This is not the CT scan. This is that reconstruction that it does, that 3D reconstruction that makes it look like it. Big fracture there, separate pubic symphysis there, big fracture here, 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 and here. Again, by the end, you'll see it. It's okay if you don't now. These are some of these are just digital created images of that virtual colonoscopy. Again, I don't have any actual ones, but just give you an idea. And then this is just more CT slices here. See, lots of pictures. All right, so now how do we talk about CT slicing when we're talking to other colleagues, or we're talking to ourselves, or we're talking to specialty people or the ER? These are your vocabulary units that you're going to need to know for this, right? Coronal, sagittal, axial. Hounsfield units, not going to test you on it, but it is a term that will be beneficial for you. But coronal, sagittal, axial, you definitely got to know what that stuff is. And it's all based off of the planes, okay? Flashback to A&P a little bit when we talked about, really the way I learn it is if you remember your sutures in your skull, this becomes really, really simple, right? Because the coronal makes slices from front to back. Your coronal suture comes across this way. The sagittal plane makes slices from side to side. I don't care if it's left to right or right to left, side to side. Your sagittal suture comes straight down, making that slice. That's how I remember it. Axial is from head to toe or from toe to head, right? It's sliced this way. So what actually happens in the CT scanner is it scans and images it in the axial plane. All of the initial images are done axially. One scan got the axial images. Then the machine can go back and reconstruct it and give you the coronals and the sagittals based off of this data. It is not more radiation. It is not another scan. It does not, the patient doesn't have to get more stuff done. It can just naturally do it. And I will tell you, most hospital protocols for your chest and your abdomen CTs, it's automatic. They just do it for you. So when you get the images, you'll have all three of these set up for you to scroll through. Most. If for some reason you don't get it, all you gotta do is call the radiology room and be like, hey, can you give me some coronals and sagittals on that? And they'll be like, oh yeah. It takes them 30 seconds for the machine to make it again and then send it over. So it's really easy to get. Invaluable information, right? Because when you're looking at different things and trying to pinpoint, like, hey, okay, so here's this cancerous tumor on the, I know that's labeled, right? Cancerous tumor. On the left kidney, right? We'll talk about why that's left in a little while. But on the left kidney, so now I need to try to figure out, okay, that's up and down. Where are we at front and back, side to side? Where exactly is this kidney when it comes to my sagittals and coronals, so they can use that for planning to know kind of exactly where it's at. Okay, time to talk about that. When we're looking at our CT scans and when we're looking at our x-rays, you are looking at it as if you are looking at the patient and the patient is looking back at you. That is how the image is set up, which means my right is the patient's left. My left is the patient's right, okay? Don't get that confused, okay? When you're looking at an x-ray or a CT axial slice, it is the opposite. It is as if the patient is looking at you, okay? Or in this case, some people like it, the feet are coming out of the screen towards you. That confuses some people, but some people like it that way, understanding how that works, because that's why it's kind of flipped, right? Because if a patient's laying supine and I have their feet towards me, same concept, my right is their left, my left is their right. I just look at it as just imagine you're looking at them, and it's like that. Which means I don't need markers on a CT scan. I don't need it to tell me left or right, because if I know this rule, I know what's their right and I know what's their left. Questions on that? That can get confusing, so if you're having a hard time with that, let me know, okay? Another trick you can do is, if you know your anatomy, and you know where stuff is, you can use that too, right? Liver is always on the right side. So as you're going through this, if you learn that this big honking organ on the right side is the liver, when you scroll through and you find liver and gallbladder, you're like, oh, that's the right side, cool, right? So that will be beneficial when you're scrolling through as well. But if you just remember left is right and right is left, that will help you. So what does that mean? It means when I go to a chest x-ray, right? If I have a full chest x-ray and I don't have a left or right marker on it, but I have the full thorax, I can tell you which shoulder is left and which shoulder is right because I know it's my opposite, because I have the whole body, right? On a shoulder, if I have just a right shoulder, well, based off of looking at that, if I'm looking at the patient, I should know what side the thorax should be on, if it's a left or a right, and we'll look at that, we'll be able to pinpoint a left or a right shoulder without the marker. There are certain body parts where you do that, the hips is another one. But an elbow, they look the same, and I don't have any other part of the body to use as reference to be able to figure that out, and that's why some need the marker. Does that make sense? We'll see some shoulders, some hips, and some things to kind of help you go, is that right, is that left? Just know it is the opposite of what you are looking at on the screen. Right? CT is the same way. There are no markers, but you should be able to look at it when we get there and go, that's a bleed on the right side or a bleed on the left side, once you learn how to see bleeds. Okay. Hey, look. Look what's there again. Oh my goodness. I think that's important. Same concept as x-ray, right? Still radiation, colors are the same, grayscales are the same. Differences here, these are your Hounsfield units. Because it's more detailed in imaging, it's also more detailed in density. You do not need to memorize these numbers, okay? You do not need to memorize the numbers. But these are your Hounsfield units. And this is why we talk about, I said it briefly yesterday, that fluid or water, blood, right? Because most blood is made up mostly of water. Fluid and soft tissue kind of look the same on x-ray and CT. You can't distinguish because look at how close they are in this range. They're right next to each other, right? Here's H2O, water and blood basically, and soft tissue, like they're indistinguishable without that contrast. How many of you looking at this? So, how many scans do you think this patient got? Without reading the words. I just realized it's on there. All right, well, one scan. All right, here we go. I should take that off. So this patient got one CT scan, but it looks like they got 3. Why is that? This is another benefit of CT.
Change the scale.
You don't change the scale, close, right? You actually have algorithm buttons. You change what's called the window. So you don't have to really change anything except for press a button on it. So what you have here is you have a soft tissue window, you have a bone window in Charlie, and then A is a lung window. Right? All the same scan, but you're telling the machine based off of the algorithm, hey, I want the lung tissue to pop out a little bit more. Now there's pros and cons to this, right? If you look at alpha, I can see that lung tissue really well and the intricacies of it. Even scroll through and see the fissures if I really want to once you learn that. But look at my soft tissue and my bones. I can't make anything out, right? That's not good detail. Now I flip to my soft tissue window in Bravo and I can see the muscles, the subcutaneous fat really well. I can see the heart and the contrast and all of that really, really well. But the lungs are just black. So trying to find areas on that is just black. That's not beneficial there, but it's beneficial for soft tissue. And then Charlie, really look at the detail of the bones, right? Look at the ribs, the scapula here, the spine. Look at that detail that you have on the Charlie or the bone window that you don't have in the other windows, right? But this is all just one scan, okay? Now, I'm not going to give you this and be like, what window is this? I don't care about that. I want you to be aware that there are different types of windows you can use, so when you're out there doing it, you don't just get Bravo, because Bravo is the scan you're going to get. It's going to come in that soft tissue window. That's the standard, right? But know that you have other opportunities to look at the other stuff to be able to evaluate what you're really concerned about. Yeah, I never know if this should be gray, like G-R-A-Y or G-R-E-Y. If everybody knows the right spelling, let me know. I don't know the difference between the two words. Let's see if I can get out of this. Okay. So, what's that? E for England. So if I want to be smarter and more sophisticated, I just change to an E. Wish I'd been more sophisticated than we are. All right. So why do I have this in here, right? Yeah, funny joke, haha. But really, just to rehash, look at your chest X-ray. Look at the detail in the CT. There's a big difference, right? But we have to counterbalance that with what is needed, not necessarily what is best, right? Yes, a chest CT is going to give me so much better detail and so much more information than a chest X-ray. But is the CT needed? Can I, this is what you're going to learn in this course, can I get the answer I'm concerned about based off of the patient presentation with a low radiation just an X-ray? If the answer is yes, that's what we're going to do, right? If the answer is no, then maybe we'll go ahead and jump to the CT. So that's some of the decision making that you'll make throughout this course as we get through some of these things. More examples, right? I know it's a lot of slides, but more examples of CTs and comparison to the X-ray. So I need the right marker on here because I can't tell the difference between a right and left ankle by just an X-ray. They look the same. And the images could be flipped around or whatever the case is. So you can't even use well, the fibula's on this side, so it must be right. You cannot trust that, right? Because as you will see when you get in there, you could turn this image 90 degrees, you could flip it 180, you can do whatever you want with it, right? So you cannot trust where the fibula is supposed to be for a right versus left. So an ankle is not one that you can determine without having the marker on there, or if I tell you it's right ankle pain, and there's some really good image that doesn't have a marker, it's right. But look at how simple the fracture looks on the X-ray. And you're like, oh look, it's just that little line right there. It's just that right there. I mean, that's a big deal. Maybe just one simple little screw, but it doesn't look that bad. Then we throw on the CT scanner, and we start to see how much more involved that fracture actually is compared to what it looks like on here. So we can get a lot of really good detail. Now, do I have my answer here to be able to diagnose or treat from a family practice setting? Yeah, probably, because it's enough to pick up that phone and call ortho, right? And say, hey, look at this X-ray. Here's the age of the patient, this is what I got. What do you want me to do before I send them to you, right? And they're gonna be like, oh, I want a CT scan of that. So what you do is you put the referral in for ortho, you order the CT scan, and then that way the patient can go and schedule it. And you may not end up seeing this because you already know you're sending it to ortho, but then when they go to ortho, we just streamline their care. As opposed to them waiting 3 or 4 days or however long to get to ortho, and then ortho going, oh, I need a CT scan. Then they gotta go get the CT scan, then they gotta have another appointment with ortho, right? So when you see stuff like this, you'll learn this in ortho, it's gonna be, call up your ortho guy if you can, right? But just showing you the difference between the X-ray and the CT and the amount of detail that you can get even with bone stuff. Here's some more. This guy survived too, by the way. This was somebody who tried to take themselves out with a nail gun. They succeeded in the process as far as doing what they wanted to do, but did not succeed in their final thing. This patient was saved. This patient did not die. Right? Question some of this kind of stuff because like there are ways you can take care of things if you really wanted to. This is not a good one. But more importantly, look at alpha. Look at the X-ray. I got a nail in the skull. I have no idea where. Even if I were to get a lateral skull X-ray, it's really not going to give me any information to really kind of tell me exactly where it's at. This is where the head CT comes in. Now, what is this black area that's behind the nail head? Anybody know? Cavitation, I heard. Air, I heard, right? As I told you, black is air, right? What it is here, it's just called artifact, okay? So, remember how metal is white, right? In the x-ray? Well, that's what it looks like there. In a CT, it's so much more sensitive because of the amount of radiation we're getting. When we have metal, it creates what's called an artifact, or a starburst effect, to where it's putting a shadow out afterwards. You see how much brighter the nail is compared to the x-ray? Right? It's so sensitive that what's happening is because of this metal, it's creating this star effect. So there is brain tissue there. It's not air. It's just called artifact because it's metal in a CT. And you can kind of even see it here on the coronal view. It's got that same aspect. There's no metal or anything here. This is just artifact that's kind of coming along. And what really makes it stand out is the hip replacements, right? Look at all of this black, all of these lines straight across. It's right up against the metal. That's artifact because of the metal hip replacements, right? That's not air, not air. So how do I know the difference between the two? Well, if I see black on a CT scan, my next question is it directly around anything that's metal? If it is, it's probably artifact. Yes, yeah, they're not cut in half here, right? It's not a thing. But that will happen sometimes on CT scans. So what does this mean? All of this area of the CT scan is pretty much worthless, right? I can't really see anything there. But there may be other areas that you were getting, because maybe you were looking here in the lower abdomen, so that you don't not, that's good English, right? I guess I should leave it as G-R-A-Y. You don't, I'm just gonna say that way, you don't not get a CT because of the hip replacements or the metal, right? If you need it, you need it. Yes?
Will it change, like you just turn down house units, like you said, you have different units?
Yes, so good question. Will it change? So you don't really, the house units are the house units, it's a density thing, right? You don't change that. If I were to change the window to a bone window, it will lessen the artifact, but it won't get rid of it, right? Because the artifact is there, right? It's how the receptors receive the information, so we can't get rid of it. What it will do primarily, if you went to like a different window, is it might make it not as bright or right around the objects. You're still gonna have all of these kind of areas of misinformation, so it's not there, but it might make it a little bit smoother right around the hip replacements to be able to see some of that stuff. Yeah, good question. Okay, so what are our pros to CT and our cons to CT, right? Pros, cross-sectional images, right? We can piece together those kind of 3D type images. It's really beneficial. We get that expanded grayscale that we talked about, so we get a little bit more detail than an x-ray gives. Data manipulation, we can do those 3D reconstructions and make the knee look really cool like it's an actual bone. Beneficial for you guys in primary care? Probably not. Beneficial for ortho for sure. And now it's fairly widely available. I will tell you there are still NTFs out there, and there are still clinics out there for my Guard Reserve folks that do not have CT scanners available to them. But there are a lot of radiology-dependent clinics that are just out in the community. That you just go to that clinic, get the scan done, and go back to your doc. So it's fairly widely available. And most of our deployed settings even have at least a 16 slice available at most of the main MTFs or FOBs or bases wherever you're going to be at, right? Cons, ionizing radiation, and it's a lot. It's a lot of ionizing radiation. To the point to where we try not to CT children, period, unless we absolutely have to, okay? And it's a stationary system, right? You can't bring a CT scanner to people. They have to go to the scanner, which is why they gotta be stable enough to be able to go out there and do that. There are some portable CT scanners that are out there now. They're super expensive. The quality is just because the technology, you can, when I have a 64 slice or 128 slice down the hall, the best I think they've gotten to in the portables is a 16 slice, I think. So it's out there, they're just not readily available for the portables, so we just consider them stationary. Yeah.
The con might also be the artifact thing from the
So I'll buy that. I'll buy that a con could be the fact that it's going to create that artifact that it has more metal, but kind of like what I was saying, I wouldn't use that as a reason not to get the CT if I need it. right? So when I'm looking at it, I'm going, what are reasons I wouldn't want to get it, or things that could cause issues? The level of ionizing radiation, I need to consider that depending on my patient population and who it is. The stationary system, I need to consider that depending on can my patient get there okay and do it safely. I'm still going to order a CT scan. Yeah, it's a con, but I should still get more information than what an X-ray is going to give me if I need it. Yeah, there's just a negative side of it. Yeah, what's up?
Would you consider an alternate imaging study if they have like a person?
So again, it depends on what you're looking for, right? Because as we get into it, which you haven't seen yet, MRIs and CTs evaluate two completely different sets of data, right? So what am I looking for, right? And so that's part of what this course is going to do, is help you understand, depending on what I'm looking for, this is what I want to order. So you can consider an MRI, but if you're considering MRI, then my argument, which you'll understand at the end, would be you probably were never going to do a CT anyways, because you're going to order the MRI because that's what you're looking for, that particular info. Yeah, and we'll get there. Uses, it's all right here, right? Abdominal pathology, pulmonary embolism we'll talk about in block 2, coronary angiography we'll talk about in block 2, trauma, fractures at a joint, really anything. There's my donut of truth saying right there, right? Really anything. I will say it is used much, much, much more often in the setting of head and neck trauma and chest and abdominal pathology. Block 1 is mostly MSK stuff, right? But it's also the intro. So we will hit a lot more CT, order a CT, order a CT, order a CT in block 2, right? But it can be used for certain fracture areas depending on what we're looking for. All right. Which way do axials go? All right. Head to toe, toe to head, don't care, but either way they're sliced across, right? Sagittals? Side to side, left to right, right to left. Coronals? Front to back, front to back. Good. Patient positioning. We talked about x-ray. We talked about how sometimes you're standing, sometimes you're lying down. You saw the scanner. Every patient is lying down. There is no standing CT. Every patient is lying down. Okay? 98% of CTs are supine. There's a few that are prone, right? And we'll talk about that later. But you don't even know that. You just know they're lying down. We covered this last time, yesterday. But CT, we're going to use contrast. If it's a repeated slide, probably important. Not everything's important is repeated, but definitely if I'm repeating it and showing it to you in multiple ways, super important. And not just from a testing standpoint, but again, from a clinical standpoint. Understanding the different types of contrast. If you don't understand what type of contrast you're ordering for the patient, you can't appropriately understand if it's safe for them to actually have that contrast or not, right? So, again, iodine-based IV or intraarterial. The intraarterial is a trick word, right? We're not actually injecting the contrast into the arteries, right? The difference between intravenous and intraarterial, it's all getting put in the vein. The difference is timing. When are they doing the scan? Are they doing the scan when the contrast is in the arteries, or are they doing it when it's in the veins? Right? Because what happens? It goes to the veins, it goes up to the heart, it goes out to the lungs, it comes back, it filters through the artery, like it does all of that. The CT scanners, your rad techs, they know that timing, right? And they will scan it appropriately based off of what you're looking for. So don't get confused, we don't inject contrast here into the arteries. Bad idea. Barium, again, GI studies, both either superiorly or inferiorly, doesn't really matter. And then the cavity space stuff, iodine-based myelograms, and then the cystograms and things along those lines. All right. So here's kind of what they look like now. I showed you one or two other ones. Now I have you a slide with terminology so you can actually see it and take a look at the difference of with contrast and without contrast. Okay? So all this is really saying is just repeating the things of CT with contrast, IV without, with the oral contrast, and giving you an idea kind of what this looks like. We will see more of it as it goes on, but I want you to have that foundation. So again, this upper left-hand one, without contrast up here. Nothing. Notice how all the soft tissue, everything, the intestines, the GI tract, the organs, everything is all gray. It's all the same color for the most part, right? We'll get into the fact that that's actually poop here a little bit later, right? Poop and air in the intestines, but all the other guys are all pretty much the same color. Now, When I shift over here, I have oral contrast. What's highlighted? The intestines, right? I also have IV contrast. See the aorta right there? Aorta is bright white. Intestines bright white. Anatomy, big piece in this course, right? How do I know that's oral and IV? Because the aorta should be gray. It's not. The intestines should be gray or blackish, grayish, right? That kind of thing. It's not. I got that contrast. This here, in this bottom right, again with contrast, just a different slice and different timing. So you'll learn this. You don't need to know this here, but you will learn that this is an arterial phase. Why is it arterial? Because all the arteries around the kidneys kind of go around the outer portion there, right? All the arteries go around the outer portion of the kidneys. You can see that's what's highlighted. Again, I have some stuff in the aorta here. I also have, again, oral contrast because this is air and fluids. This is bowel. This is bowel, okay? Don't get hung up on that right now. We hit block 2. We hit a lot of admin stuff, okay? So just want you to see what contrast versus non-contrast looks like. So for this block, don't bash your head against, whoa, which body part is this all right now? We'll get into that, okay? And then just here's multiple different images. It's more of a venous phase. You can still see how the liver is highlighted here, right? It's definitely brighter than, say, the kidneys. So they timed this to catch the contrast in the liver, right? There's some stomach. So there's still, because there's air and stuff in the stomach. So you can see different phases and how, depending on how they time it, they can give you different things highlighting contrast-wise, okay? There is something called triple contrast, which is IV, oral, and rectal. Super rare. Almost never order that. I don't think I've ever ordered it in 8 years of practicing. But if you see it somewhere, not on my exam, but if you just ever see it somewhere, that's what that is. I mean, can you imagine like IV contrast and then make them drink the stuff and then give them rectal contrast as well? Like that's a really sick patient, and they're just, some specialist is just like, I want to see everything. I want to know what's going on because I have no idea. You guys will never order a triple contrast, I don't think. All right. So again, we just talked about this, CT with contrast, right? It's going to be timed, so it's going to look at the areas, different areas of the body and the vessels depending on what you're looking at. The angiogram, CT angiogram, same concept as a CT with contrast, right? It's just a name for, I'm specifically looking at the arteries, the main vessels, okay? Angiogram is basically a study of the arteries. Does anybody know what artery this is? You will. So someone said necessary, what area of the body am I in? Thorax, right? Chest area. So it's not the arch, it's close to the arch, you're in the right area. It's the pulmonary artery. This is the main pulmonary artery, okay? You guys haven't seen that yet from an A&P standpoint. You're going to see more pictures of this in block 2 for sure. So when you get your PEs, pulmonary embolies, a lot of times this is the area we're concerned about because this is the main pulmonary artery. You can have them in some of the smaller vessels, which we'll look at later, but that's the main artery that you're evaluating for to look for a pulmonary embolism, right? And that's where it says the contrast is timed, right? So they have to catch this when the contrast is in the pulmonary artery. It doesn't just sit there, right? But there are very good protocols that are timed. We know how many seconds, and it's actually kind of cool. I wish I could show you. What we'll do as rad tech sometimes is we'll actually have this image on the scanner, and it takes a picture every like second and a half. So we're watching it fill up, fill up, fill up. We're like, it's bright, scan, and then you get this pretty little picture for you. So pulmonary artery, descending aorta. If I were to scroll up a little bit, just a couple of slices, I would have that aortic arch because it's already split here, right? This is coming out from the heart, going up to the ascending aorta. This is the descending. It's already been split on this slice. You see that? So there's the two different aortas. The arch is just slightly superior, and we will see some pictures of that down the road. I'm not going to test you on this, but there's a couple of slides in these lectures that, and I'll tell you which ones they are. This is one of them that I'd like you to pull out or use for your phase 2 in your clinic. I'm trying to prep you guys. I know it's like 10 months away. You're like, I'm not even thinking about that. But there are a few things that are very beneficial for you to just have readily available. And this is when do I order a CT with contrast or without contrast? Because there are certain things in the green that have very high sensitivity without contrast and then with contrast, right? And you want to know this because the last thing you want to do is A, give contrast to somebody who doesn't need it because you could cause potential harm or side effects, right? Or worse, in my opinion, scan somebody without contrast and realize you didn't get the information you wanted and now they need to get scanned again, right? We don't want that. How does that appear on CT? What color? Black, same as X-ray, right? These are to hit home. That is the same as X-ray. Metal, white, bone, very light gray. Soft tissue, gray to dark gray, gray to dark gray. Questions about CTs from a foundational standpoint. Know your slices. Know the colors of things. Understand that fluid or water or blood and soft tissue are the same unless we give that contrast. Know which contrasts are for what. Know your contraindications to giving contrast. For this block, that's pretty much your foundation for CT and what you need. Okay? We'll talk a little bit about head trauma and stuff like that in the later lectures, but all right. Mammo. Why are mammograms important? This is why. Yes, this is why. You are going to have a lot of patients that don't want to get it done. All you can do is say, hey, 1 in 8 women don't die. But if they say no, can you force them? No. But if they say no, what do you have to do? Counsel them and then do what? Document it. Offer patient mammogram, patient decline. Fantastic. Because I hate to say it, but sometimes in medicine, that patient ends up with breast cancer. You don't want to be the one that gets sued because you didn't recommend a mammo to them and didn't catch it early. Unfortunately, in some cases, we have to act that way. Since mammos have started, recommendations, 40%, I got to update this, I think it's more now, but from 1989 to 2017, instances of breast cancer dropped by 40%, or I should say deaths from breast cancer dropped by 40% since we started screening. So we're going to cover just some brief mammo stuff. Okay. All right, so mammo started in 1913. Looking into it, really screening mammo started in 1970. It wasn't super popular then. People were still like, I don't want to get this done. Why do I need to? Late 1980s when it became a big thing. There's what the machine looks like. This is the machine. This is the control panel. This is the machine. This is the control panel. All right? It's upright. The patient stands. And this thing can be maneuvered different angles all over the place to make it as comfortable as possible for the patient. Listen, I never had one done, but I recognize that it's uncomfortable. Please make sure you tell your patients, especially my male providers in here, recognize that it's uncomfortable, right? But the importance of it when it comes to that, to stop or to screen for breast cancer. And take a break from here. We'll dive into the 2 types when we get back. Keep those coming. If they're super valuable, I'll tell the whole class afterwards. One of the things that came up was like, hey, looking at these things, trying to know normal so that way abnormal jumps out, right? How do I know normal? Looking at a bunch of stuff. One of the things I mentioned on radiopedia, something you can do to help yourselves out. Now, when we get to the MSK lectures, sidetrack, I'm going to go over normal for every body part that we're going to look at. I'm going to show you normal x-ray, I'm going to go over it, tell you what anatomy is what, where it's at, and then compare it to the abnormal. So we'll have that in lecture together, and I'll be able to answer those questions. But also for those that are, high speed or kind of want to get ahead, help get understanding, when you go to radiopedia, you could put like normal shoulder x-ray and it'll pull it up. You can also put normal shoulder x-ray annotated, and it will give you a normal x-ray and give you an annotated x-ray. So it'll have lines and have like stuff labeled on the x-ray. So say humeral head, humeral neck, humerus, right, clavicle, chromium, that kind of thing. So that way you can actually look at it on radiopedia as well, in addition to what I'll have in the slides. to help you see where those anatomy body parts are, right? Where is the coracoid? Where is the coronoid? Different areas of the body, right? So those kinds of things. So you can put annotated in any of your normal x-ray searches on Radiopedia, and it should pull those up with everything labeled for you. All right, back into mammals. So there's the machine, right? It can rotate around and everything. It uses radiation. We'll talk about why we still can use that, even though radiation causes cancer, but yet we use radiation to screen for cancer. That seems counterintuitive, right? Well, the amount that is needed for a mammogram is even less than that chest x-ray we talked about. It's not very much. And that's part of the reason why the machines try to compress the breast tissue as much as possible to use as low of a dose as possible. So the relative risk of radiation versus the risk of not finding a breast cancer early has been deemed years ago as an acceptable risk that we're gonna go ahead and take. Two different types, right? Two different types of studies is gonna be screening and diagnostic. So understanding your age population and understanding what to order is probably the most important part of the mammography section, right? You guys are not going to be interpreting mammography studies, okay? This is going to be done by a radiologist who has a certification in mammography because it's so important from a breast cancer standpoint that not just anybody is authorized to do that. So you will never really have to interpret a mammo study, but understanding what kind to order based off of what the patient's situation is important because they can only scan what you order, right? It's that simple. If you order the wrong thing, they just gotta come back and say, hey, they told me you ordered the wrong thing, and they gotta go back and reschedule, right? So, diagnostic, asymptomatic patients. Screening. I apologize, go back. Screening, asymptomatic patients. Why? They have no symptoms. I'm just checking to see if you have any breast cancer, early onset breast cancer. Annual screening, I think right now still begins at 40. Okay? Now, how often depends on what guidelines you look at. Some of them say a year, some of them say every 2 years if it's normal. There's USPSTF. I'm not getting into that guidelines. For us, we're going to say annual mammographic screening begins at 40. Okay? That's what we're going to call it. I've seen some guidelines say 2 years. I still recommend it annually to my patients because it's worth it. Diagnostic happens in 2 situations. Patients who have symptoms, pain, discharge, masses, right? Or patients who don't have symptoms, but they got a screening one done, and there was something noticed on the screening. Because the screening is less radiation. The screening is just what it is. It's a screening. It's not super detailed. The diagnostic gets more into the weeds of different types of angles and pictures and a little bit more radiation to make things kind of pop up more for the radiologist to be able to look at it. So anybody with breast symptoms will get a diagnostic, or if you have abnormalities on your screening mammo, you get a diagnostic next. Tracking? Okay, so far pretty straightforward. No symptoms, 40 years old plus, annual screening. Symptoms or abnormal screening, you get a diagnostic. Here's where it gets a little more convoluted. If you have breast symptoms and you're 30 or older, it's what we just talked about. If you're under 30, we do an ultrasound first. We don't jump right to mammo. Why? Radiation, right? You're under 30. You're younger. Your breast tissue is younger. So we're going to do an ultrasound. It's not necessarily as good as a mammo, but because you're under 30, and we know once you turn 40, you're getting them every year for the rest of your life. So this is where the guidelines draw the line. They draw the line at 30. They said it's worth the risk up until 30. Then we want you to do an ultrasound. So age is important. So if you have a question where you're asking like, hey, what's the study that we ordered? You got to go to that vignette. You got to look at the age. You got to figure out their symptoms and out what's going on to be able to know what to order. So ultrasound for under 30 with breast symptoms. 30 or older with breast symptoms, you get the diagnostic mammogram. Okay? I even have it down here at the bottom again. Ultrasound is the initial study in average risk symptomatic patients under 30. Under 30. Now, what'll happen a lot of times is you may do your screening, and maybe it was inconclusive. Well, then the radiologist will come back and say, hey, dense breast or fibrotic breast, couldn't really get a good assessment of what's going on. Please order additional views, or please order an ultrasound, or please order an MRI. You don't need to worry about that. If you just learn this, you'll be fine, because then the rest of it, you just go off of the radiologist's recommendation. Oh, you said order an ultrasound? Okay, I'll order the ultrasound. Go schedule it. Right, it's that simple. But you gotta know the initial test to schedule. Here's what they look like. I'm not gonna make you read or dictate or anything like that a mammogram outside of describing maybe the lesion that you'll see, right? Because describing a lesion is important if you're talking to somebody, but I don't need you to, like, other than describing something, a lesion that you see, that's all I'm gonna ask you to do if I give you a mammogram image. It's more important that you know who needs what and what kind, okay? But these are what they look like. So you see the breast tissue, get the tail of the breast up here, and then that's all normal, right? This is all normal breast tissue. This was 2 different mammograms that were put together for good comparison. They were not shot at the same time, right? They didn't have like 2 different things, like no. This was one done, another done, and then it was put together so that way the radiologist can look at them and compare them a lot easier. Here's kind of how they get done, right? Very similar to an x-ray. This is still radiation, right? And it's named, right, for the way the x-rays go. So x-rays, it's right breast, craniocaudal. So it's going from the cranium down, caudal view. Right, medial, lateral, oblique. The x-rays are coming from the medial area and shooting laterally on an oblique angle, okay? Why is that important? Because what's gonna happen is sometimes in the reports, the radiologist will be like, hey, we did this, we need an RMLO view. So you gotta know how to write, oh, it's right medial, lateral, oblique, okay. So they do the right thing. But that just gives you an idea of kind of how they name the mammogram. This is how the x-rays are shooting. Here are the lesions we're talking about, right? Being able to describe that would be important, and we'll talk about how to describe it. I do not expect you to pull out that red arrow as a cancer. I do not expect you to pull out that red arrow as a cancer, okay? I don't. Just showing you though how minute some of these changes can be. That's where we have radiologists that specialize in reading these things. This, once you start seeing more, you should be able to realize, well, that shouldn't be there. Do I expect you to know it's a reactive lymph node? Absolutely not. Absolutely not. That could be a cyst. That could be a reactive lymph node. I don't know. But you should be able to call that a well-circumscribed round lesion. Right? Just basic medical terms. Well-circumscribed round lesion. That's what I need you to be able to do when it comes to looking at mammal imaging. This is going to be for your phase 2, right? What are the different BI-RADS categories based off of the different breasts, okay? So those category 4s, you can see why those would be the ones that they may go, hey, I need an ultrasound, bless you, whoever that was. You can see why in that category 4, they'd be like, hey, the mammal's not enough. I can't make out dense tissue versus cancer and abnormalities in that. I need an ultrasound or an MRI depending on whatever they ask for. Whereas category 1s and 2s, a lot easier to start pulling out any large masses that are sitting in there based off of the density and the radio opaqueness of the breast. Look at that. Don't worry about this slide. I gotta take it out. I'm going to take it out. It's FYI. I have a few slides that are FYI. They're extra information for those that like it. Not testable. Not going to go into too much. So you can ignore that slide. So I just covered it, right? But just to read it, why is it difficult in dense tissue? Because it's already more radio opaque, and so are going to be the lesions. Okay. This spiculated, well circumscribed, right? Those terms are what's important. So, normal mammo, benign cyst. See, that cyst looks the same as that reactive lymph node, right? which is why I don't expect you guys to pull those out. But you should be able to look at it and go, well, that's a well-circumscribed lesion sitting in the breast. I will tell you for generalities, things that are well-circumscribed and kind of like on their own, probably benign. Things that are not well-circumscribed and are kind of what we call spiculated, and like I can't, like, where does it end? Like here I can definitely tell you where the lesion ends and where the breast tissue starts again. Here, that's really hard to tell. And look at it compared to the normal mammogram. That is a bright white lesion that is not well circumscribed. That's what we would call spiculated, centrally dense with weird margins kind of out there. Know how to distinguish between spiculated and well circumscribed. Because this versus this, much more concern for your patient, so you can be a little bit more adamant when the radiologist is like, hey, you should get a biopsy. You're like, I don't want a biopsy, it's painful. Maybe I would push a little bit harder on this one than I would on the well-circumscribed one. Be like, you really should get that done. So here's a good slide with words to kind of describe the different shapes, the different margins, the density, right? So we talk about circumscribed, obscured, oval, round, irregular, just describing the shape, describing how well those margins look. I really care more about circumscribed versus indistinct or spiculated. Those are the two words I would have in there. Density, right? We saw how it's more radiopaque than the surrounding breast tissue on both aspects of it. Spiculated and cystic, these are the two terms we're going to use mostly. Mobile or fixed. Mobile or fixed is more movement. That's going to be a physical exam finding, not a radiological finding, right? You can't tell mobile or fixed on a mammogram. But if they had symptoms, the odds are you probably did a breast exam in clinic, right? That's going to go more under your physical exam findings of is the lesion mobile or is it fixed? Same thing with fluctuant, rubbery, or firm. If you find a mass in a breast, some of these words need to be in your mammogram order, right? Patient with right breast pain, fixed, rubbery lesion noted at 3 o'clock position. Now you've told the radiologist why you sent them and where the area of concern is. That's why these are in this slide, because you need to know that in order to write the order, right? Mobile, firm lesion with tentative palpation at 9 o'clock position of left breast. Great. They're going to look at the whole thing, but now they know where to focus in on when they're doing their studies. Pros and cons for mammo. Inexpensive, readily available, portable, and quick, just like x-ray. Cons, it's ionizing radiation, but we've already determined that if they're over 30, the risk for the radiation is worth the benefit of finding early breast cancers, right? Uses, screening, breast exam, and diagnostic. Patient positioning, not really a concerning factor. They can be sitting, they can be standing, because that machine can go up and down to a height, and you saw how it can angle to get different views depending on how the patient. You can do mammos in patients in wheelchairs. You can do mammos in patients in hospital beds. They bring them down to the radiology department. They just got to lean over. So, not really a factor for this one. Right, benign breast finding and neoplastic lesion, that's going to be that well circumscribed versus spiculated. Those are the two I need you to be able to distinguish between. What's going on here? Breast implants. I had a good question on break. Do breast implant patients still get mammograms? The answer is yes. Still order the mammograms. If it's screening, the answer is yes. What is going on here? Nipple piercings. Should those be removed prior to doing a mammogram? Probably. Can they all be removed prior to doing a mammogram? Not necessarily. So before you get on your rad tag and be like, what the heck is it? Maybe they were not removable. There are piercings that skin grows back over it and everything, and they're not removable. That's a very good possibility. So anyways, these are your breast implants. There are two main types. There are the subpectoral and the prepectoral, and if you look deeply at the mammogram, you can see the difference, right? You can see the line of the pectoral muscle kind of come in right here and see that that implant is below the pectoral muscle, There's that black line, that is the edge there of the pectoral muscle. And then you have your pectoral muscle here, and you have the prepectoral where the breast implant is on top of the pectoral muscle. Those are two different types. But as you can see, I still have a lot of breast tissue that needs to be evaluated that could be cancerous. So the answer is yes. If you have breast implants, you still get mammograms. No, the mammogram machine is not going to rupture the breast implant. They don't squeeze them that hard. They have different protocols. I would put in the history, 45-year-old female with breast implants due for screening mammogram, so that way they know they have breast implants in case the patient doesn't say something, because sometimes they don't, I don't know why, but they don't. So ask that question so you know how to order it, but yes, they still get mammograms. Hey look, it's our first blue study of choice. Breast MRI is the most sensitive of all the breast imagings. However, because it is super expensive and it takes a really long time, and we really don't need to use it a lot, the only time we use it is in patients who have breast implants and the concern is a rupture of the implant. Not the concern for breast cancer, the concern is the rupture of the implants, specifically the silicone implants. If they're saline implants, it's fine, it's not going to hurt the patient, right? But the silicone implants will harm the patient if there is a rupture or a leakage and it doesn't get taken care of. It can cause infection. So MRI study of choice in breast implant patients when the concern is on the structural integrity of the implants, not when the concern is just standard screening or diagnostic mammo for breast cancer. Here's what they look like. You will never have to read this. You will never have to dictate this, but they have a very special little kind of holder here to be able to really take a look at this. This is just one view. Understand an MRI is like a CT. You have lots of slices you go back and forth on. This is just one picture to give you an idea of what it looks like. Not going to make you read this. Just want you to see it, right? This is what the important part is. This is what's important. And knowing that just because they have breast implants does not mean we automatically jump to MRI. It depends on what you're trying to evaluate. Okay. Questions about mammo? What do I need you to know? Go ahead.
In a situation where you had a patient where you had concerns of breast cancer but they refused to get mammogram, it would be possible to offer a breast mammogram?
No, because it's not going to really evaluate for that, right? My next question would be, so for those that didn't hear it, the question was, you have a patient, you're concerned with breast cancer, but they refuse to get a mammogram, can you offer an MRI instead? The answer is generally no, because they evaluate for different things, right? Which is why there's that hard line. If that was the case, everybody would just get the MRIs if it was that good for finding breast cancer, because now we can find the answer and we wouldn't have to give the radiation, right? But we don't. So my response to that patient would then be asking what their concern is with the mammogram, right? Because if we already suspect breast cancer, the radiation should be the least of their concerns, right? And so they may say that, so you can say, hey, heard, but it's very low, and honestly at this point, ruling this out I think is way, not evaluating for this potential deadly disease is way more risky than just a little bit of radiation for the mammogram, right? And just try to appeal to their common sense a little bit, but all you need to do is offer. But no, an MRI would not be appropriate in that case.
How many round trip flights would it?
Say again?
How many round trip flights would it? How many round trip flights would it?
Oh, round trip flight, that I don't know. That I don't know. Less than the chest x-ray, so less than one, right? I don't know that. Like that, that's good. You'd be surprised how many like little 85-year-old like men and women are terrified of even like a hand x-ray because of the radiation, because they hear on the news of somebody got cancer from medical radiation. Yeah, you know who that was? The guy who probably is in interventional radiology and has had like 60 CTs for evaluation of something else, and it just compiled, not the person who sprained their wrist and needs a wrist x-ray, right? So you have to have that conversation, I promise you. Other questions about mammo? Okay, know what to order based off of age and whether or not they have symptoms or not. Know how to describe a lesion and what it looks like as far as just well circumcised versus spiculated, and which one's good and which one's bad, right? And understand the indications of when to order that in MRI breast. That's what I need you to know from mammo. We're not gonna read any more mammo studies. We're not gonna dig into any more mammo pictures, right? That's all the mammo you need to know for this course. MRI, same stuff. Very important, right? Bad joke, I know. Just don't ask your dog to do it, like a cat can. I know. But a little bit of history on the MRIs, right? So really kind of discovered it in the early 40s or late 40s, early 50s. Didn't really start getting used right away in that aspect. But again, really started getting used for cancer in the 70s. And then it was finally in 2003, we got another Nobel Prize here for like using the different gradients. I want you to see, we do have portable aspects, but look at the quality of the portable compared to the standard. All right? Same concept with those CTs that are coming out. That's the difference in quality. It's really not great. But MRIs, there's the machine, thicker. A lot of them are a little bit bigger. This is more kind of an open one where the whole body doesn't go in, but a lot of them are much longer. Anybody here ever had an MRI? You're not telling me what of, right? That's a long tube. It's very tight. And they take a long time. Like 45 minutes is like the quickest scan. Quickest. It takes a long time. And if you're like me, you get an MRI and you fall asleep and you twitch, then you're like, sir, can you, we need to redo that one. Can you hold still, please? Sorry, fell asleep. Yeah, in there. So, they don't use any radiation, right? They work similarly to CT. The difference is instead of radiation, they're using magnets. And they put out a magnetic field, okay? But there is no radiation involved with these guys. The images produced look very similar to CTs as far as our slices go. So we're still going to have axial, we're still going to have coronal, we're still going to have sagittal. But if you remember back to yesterday, look at how smooth these pictures look compared to the CT, right? I don't have that graininess, I don't have that noise. It's a lot smoother when I look at the muscles and I look at the bone. Now, the trick with MRI is I can't tell you what's white, what's black, what's gray. Okay? Because MRIs have two different settings. Briefly being one of the slides, you don't have to memorize this. But the reason I say that is I don't want you to get hung up on that because you can see these three images of the MRI and look at that. In the middle one, the bone is black. On the other ones, the bone is whitish, grayish, right? It's different settings, T1 versus T2. You don't have to worry about that from your level, but just understand we can assign colors to CT and X-ray, and what we will talk about in ultrasound, we cannot necessarily assign concrete colors to MRI because it just depends on how the scan and what they're looking for. But do know the difference of being able to tell if you're looking at an MRI image or a CT image, right? And also coronal, axial, sagittal. Be able to tell the difference between the CT image and the MRI image. Okay. All right. This is going to talk about how the MRI machine works, right? YouTube, go ahead and take a look at that if you want to. Here's the words on that, right? So without getting into like super into the weeds and details, what it is there's a radio frequency pulse, right, which uses magnetized protons. Remember, X-ray and CT uses electrons that turn into photons, which create radiation, not protons. Protons are magnetic, okay? So they use magnetic fields to emit an energy that gets picked up by the coils. Here's that T1, T2 I was telling you about, right? Not going to be tested, but look at this. I got bright white brain matter and then dark brain matter. You see how the colors are flipped, but depending T1 or T2. Same lesion, just looks different, right? That's why we can't assign colors to things. It just depends on how it's scanned, right? But I do want you to focus on the smoothness of the images. Look at this. I can also I can see the spinal cord. Look at that spinal cord coming straight down. And that's cerebral spinal fluid, the white around it. But then when I flip to my T1, I have a gray spinal cord with black cerebral spinal fluid. But this is still the only imaging modality that I've been able to see the spinal cord on so far that we've looked at, right? Actually see the spinal cord in the CSF. Also, I can see the little intervertebral disc spaces here, right? Why? Because MRI is best used for soft tissue things, okay? Ligaments, tendons, spinal cord, cerebral spinal fluid, sometimes brain, but brain chronic, right? Brain acute is going to be CT, and we'll talk about that later. But intervertebral discs, the spinal cord, CSF, tendons, ligaments, labrums, right? The hip and the shoulder, the soft tissue labrum in there. All of that soft tissue stuff, that's what MRI is for. MRI is not an emergency study. There is no such thing, maybe some more pictures here. There is no such thing as an emergency MRI, right? So if you ever have a patient who's in an ER, and this will help you when you're in ER in senior semester and ortho next semester and stuff, that they're in the ER and you need a scan like now, MRI is not your answer, okay? Now you're going to get the soldier or the airman, right, that comes in with a hurt shoulder for 3 days and be like, I need an MRI. And you'll have to have that conversation with them of not ordering the MRI, and we'll get into that, because MRIs are not emergent, okay? What is the main reason we do MRIs for? What's that? Soft tissue, right, okay. So, I haven't told you this yet, so I guess what I'm thinking. I think I might have heard it. Surgical planning. Surgical planning is the main reason we'll do MRIs, especially on musculoskeletal stuff, right? So when you have those patients that come in with the knee pain, or the back pain, or the shoulder pain, and it's just like acute on chronic pain, when you learn your physical exam skills, which you are learning now, and you'll learn more in ortho, if you don't have a finding that suggests that they might have something surgical, you don't need the MRI. And sometimes that's what you have to explain to the patients. Like, hey, you want surgery? Like, no, I don't want surgery. Well, if you don't want surgery, and I don't think you need surgery, there's no reason to get the MRI. Because that's really for the surgeons to do surgical planning. Now, there are other uses, right? I'll be clear. There are other uses for MRI. But for what a lot of you guys are going to be seeing, that's kind of how you can distinguish of do they need it or not. Yes, chronic conditions that maybe you evaluate some stuff, you're like, I need more information. But the most common MRI request comes from patients wanting musculoskeletal MRIs because they think they tore a meniscus, or they think they tore their labrum, or they tore a hamstring partially. Great, good for you. That's just PT and rest. An MRI ain't going to do nothing because they're not going to surgically fix your hamstring, right? Unless you've completely torn it, like all the way. So you got to tell patients, like, even if you had a torn muscle, they're not going to go in there and surgically fix it. So the MRI does us no benefit when the treatment plan is exactly the same. Rest, PT, vitamin M, right? And get back out there. So, but this is talking about the T1 and T2s for those that want it. I'm not going to test you on it, but it just shows why we can't do colors like we can for the other radiological studies, okay? ACL, right here, ACL. It's there, it's intact. I can see it flat connection here to here. I'm not going to make you read MRIs, by the way, either, outside of like one or two little things. No ACL. Starts, does not connect. This is a torn ACL on your left compared to an intact ACL on your right. This is where an MRI is beneficial. But how are you going to know this? You're going to do your physical exam, and they're going to have a positive anterior drawer or a positive Lockman test, and be like, ooh, let me do the other knee. Ooh, that's way different than the other knee. I think you have a torn ACL. I'm going to order an MRI and send you to ortho, right? Because you had something that determined that this is what's going on. Most of the time, you don't even need imaging to make that diagnosis. But who needs the imaging? Ortho to determine if they're going to do surgery or not. So you're going to do the solid, you're going to order the MRI, and then send the patient to ortho. It's just what a brain MRI looks like. I mean, like, it's just fun. You can't get this kind of detail anywhere. I've never ordered a brain MRI. This was likely ordered by a neurologist for some extra reason. I just think it's one of the best brain MRI pictures I've seen, so I put it in here so you can see what it looks like. All right, so what are the pros for MRI? No radiation. Cross-sectional imaging, standard grayscale, data manipulation. All the same as CT. The extra benefit is no ionizing radiation, right? The cons, super expensive. Not readily available, right? Most of the places you all are going to be stationed aren't going to have MRI machines. If you're at a big hospital like BAMC, right, for the Air Force, Travis, all your phase 2 sites, they'll have MRI machines most likely, but a lot of the bases we're at don't have them. You gotta send them out on the economy to get it done. No ferromagnetic objects, right? They can't have any metal in them. This becomes an issue in our soldiers if they have shrapnel from back in the day, especially our retirees. Maybe got some shrapnel from the Korean War, or some of our Vietnam War folks who are still alive, right? Asking those questions is important, because if they get an MRI and they got some old school shrapnel, guess where that shrapnel's going? They ain't gonna have it anymore. And it's gonna be super painful, right? Because it will pull that stuff out. Piercings usually can be removed, but unremovable piercings are a major concern, as we talked about. There are unremovable piercings on patients. Those patients can't get MRIs if they can't remove the piercing. Can't do it. It'll rip it right out, like legitimately. Stationary system is a con, and it's really slow. I just talked about having to remain hold still, like 45 minutes. Some of these things are 3 hours when they got to do like the brain and the C-spine and the thoracic spine, because each one is individualized. And unlike the CT where I do one scan and then the machine kind of like does all the different things for me, MRI takes a scan, then they set up a new scan and scan it a different way, and that's why it takes so long. So super slow. What do we use it for? Study of choice on a lot of things is blue, right? For neurological imaging, we talked about that, spinal cord, brain, that kind of thing. Soft tissue around the joints, that's going to be your bursas, your labrums, okay? Your tendons, ligaments, that kind of thing, spinal cord pathology. Female pelvic organs, it's second line. It can be used for female pelvic organs, but it's second line. Ultrasound is your first line. Now it's on here because it can be used, but it's not the main study of choice. That's going to be ultrasound when we get into that, okay? All the patients are lying down, prolonged periods of immobilization, 30 to 45 minutes. This one's not like CT. It's not like it's mostly supine, right? It just varies on the study. Some are supine, some are prone, but they are all lying down. MRI does have a contrast. We haven't talked about it yet, right? MRI does have a contrast. It is gadolinium based. It is not iodine based, it is gadolinium based. So if you're ordering an MRI with contrast, that's going to be gadolinium. It's what shows up with the magnetic resonance. If you put gadolinium in for like a CT, it won't show up. The iodine stuff isn't going to take for an MRI. So gadolinium is your MRI contrast. Risk and complications, very similar to the iodine-based stuff for CTs, but it's less likely. It doesn't happen very often. It doesn't get used very often, so there's a lot less reactivity and issues with allergic reactions and things along those lines. Yes, if you have heart disease or kidney disease or liver disease, it gives you a high risk of complications, same as the iodine contrast. And pregnancy, don't do it, right? Pregnancy is bad too. We don't want to give contrast to pregnant patients. Avoid the repeat exposure, and nephrogenic systemic fibrosis, right? That's a kidney disease, so that's a no-go. So very similar to the contraindications of the IV contrast for the iodine-based for CTs, but it's just not as common. Part of that could be that the MRIs with contrast aren't ordered as often as the CTs with contrast are, maybe. We just know there's less incidences of complications from the gadolinium MRIs. So here's another one, kind of shows you what an intact labrum looks like. So now the way these work is these are called arthrograms. So what they do is, remember how I showed you that that fluoroscopy where they watch the needle go into the joint, right? So what they'll do is they will inject, they'll do that fluoroscopy first, and they will watch the needle go into the joint, and they will inject the gadolinium-based contrast into the shoulder joint area here between the glenoid and the humeral head, and then they send them for the MRI scan right afterwards. I've had one of these done. Makes their shoulder feel really full, like it's swimming. It's kind of weird to get all that fluid in there, but it's so that way they can get a good visualization of the labrum and to see if it's torn or not. And you can see how clean this line is, comes across. There's really no inflammation, no major issue. Everything's kind of together. Again, I'm not going to make you read MRIs, but if you just compare the normal to the abnormal, you can see the difference, how angry it is, how it's torn. It should be nice and in there, but it's torn, so some of that contrast has gotten up in behind the flap a little bit or come out of there. So this is a torn labrum here compared to the normal. That's how that study is done for the hip and the shoulder. They inject it directly into the joint and then send you to the MRI scanner. Body will reabsorb this on its own within a day or so. Like I think the next day, like I was feeling just fine. So, but that's how you eval that. However, you have physical exam skills that will tell you if you think you have a torn labrum in the hip or in the shoulder. So if that's negative, this is most likely not needed. Right? So this would be done after you notice that, or they've done PT, the x-ray is normal, you know, and they're still not getting better. Now maybe I'll jump to that MRI because I've tried all the non-invasive stuff first. All right. So what kind of study and slice or plane do I have with all the labels, the one on your left? What is this? Sagittal what? Sagittal MRI. Then what's on the right? What kind of slice? Sagittal CT. Look at the difference. Look at the graininess, look at the smoothness, look at the difference of how the bone appears, look at the difference of how the soft tissue appears between the two. Okay? Know what you're looking at. Know what you're looking at. Benefits of MRI, right? Lack of radiation. We already know that, and all the same benefits as CT. Drawbacks is that it's expensive, less readily available, slow, stationary system. Some of the uses we just talked about. And this is why it's important to make sure they don't have any ferromagnetic material on their body, because things like this will happen and have happened because somebody left a patient bed in the room and they turned on the scanner. Yeah. And that is a lot of money right there, folks. These machines on the cheap side are $3 million. On the cheap side, an MRI scanner is $3 million. They can be upwards of $10 million for an MRI scanner. Right? So, don't be the one who has to have a report written on you because you're the one who left this in the room. Because somebody had to think of that. Questions?